So keeping in mind that the session is meant for postgraduates, I have prepared my talk accordingly. So I'll be discussing the key points in the management of ptosis. And before that, I'd like to go through how you should evaluate the important points in ptosis workup. So you know that ptosis is basically the drooping of upper eyelid from more than 2 mm. So we can classify it as congenital or acquired, or etiologically we can classify it as myogenic, aponeurotic, mechanical, and neurogenic ptosis. So first, slides. Yeah. First and foremost, you take it, children. So first, many times in from here, or what the slides?
You tell
Yeah.
next.
Okay.
It'll be awkward, but we have to be.
Okay, so this is the proforma for the ptosis workup. We start with the visual acuity and pupil. So why it's important to look for the visual acuity? Because ptosis in severe cases, it can cause amblyopia. And it's not the stimulus deprivation amblyopia, which is the most common variety, but it's the anisometric amblyopia, which is because of your pressure of the eyelid over the cornea that causes astigmatism. So the most important amblyopia is the anisometropic, and followed by stimulus deprivation amblyopia. Pupillary examination is important because sometimes in neurogenic ptosis, like in Horner syndrome, you may get meiosis, and in third nerve palsy, you may get mydriasis. So you have to look for the head position of the patient. In bilateral severe ptosis, patient may have some chin-up position. Also look for frontalis overaction, because in severe unilateral ptosis, patient may have a raised eyebrow because of overacting frontalis muscle. Look for the position and presence of lid crease. So if the lid crease is absent, then we can say it's a ptosis with poor LPS function, and usually seen in congenital variety. Whereas if the lid crease is present, then it indirectly denotes that the LPS function is good. It's high and deep in aponeurotic kind of senile ptosis, whereas it's absent or faint in congenital ptosis. MRD, that is the margin to reflex distance, is important to calculate the amount of ptosis, and we can divide or grade the ptosis accordingly into mild, moderate, and severe variety. In the mild ptosis, the amount is 2 millimeters, and moderate is 3 millimeters, and severe is 4 millimeters or more. Always look for a compensatory response in the other eye, and there may be a lid retraction because of the Herring's law of innervation when there is a unilateral severe ptosis in one eye. To measure the LPS function, you ask the patient to look down and take a ruler and ask the patient to look up. And the excursion of your eyelid from maximum down gaze to maximum up gaze will signify the amount of LPS action. And you can grade it into fair to poor and good. Poor LPS action, we say if it is less than 4 millimeters. Fair is 5 to 7 millimeters, and good is 8 or above. Now you have to look for lid lag in congenital variety of ptosis, because the LPS muscle is dysfunctional, it's fibrotic, and it's not able to relax properly. So whenever the patient will look down, you will see some lid lag, and lid droop is there in aponeurotic variety of senile ptosis. Bell's phenomena is very important preoperatively. If the Bell's is poor, then we do not go ahead with the surgery. Bell's is the outward and upward movement of the eyeballs when patient tries to close the eyelids. So how you can grade it? If less than 1/3 of the cornea is visible, then it's called as a good Bell's. 1/3 to half of the cornea is visible, it's a fair Bell's. And if more than half of the cornea is visible, it's poor Bell's. Marcus-Gunn jaw winking phenomena, it's a variety of complicated synkinetic ptosis. When the patient moves the jaw, the eyelid also moves along with. There is an eyelid retraction on the jaw movement because of the supply of the mandibular nerve to the LPS muscle. It's important to do a dry eye workup, triofilm evaluation, and corneal sensation or Schirmer's test before any ptosis surgery. Always look for old photographs whenever in doubt that it's a congenital or acquired ptosis. In myasthenia gravis, you can just do an ice pack test in the OPD. And phenylephrine test is of paramount importance if you are planning to do MMCR or facial lata surgery. In blepharophimosis syndrome, you must look for any family history. Always ask the patient for any morning edema in cases of blepharochalasis. In myogenic ptosis, you may have decreased extraocular movements and poor Bell's phenomena. So in these cases, you may prescribe crutch glasses and you should not go ahead with the ptosis surgery. Surgical management is aimed at the functional goals of clearing the visual axis as well as the aesthetic goals of symmetrical eyelid position. Now, when you should do the surgery, it's advisable to defer it till 3 to 4 years of age until and unless it's unilateral or severe ptosis causing amblyopia. Surgical procedures are many and you can decide according to the amount of ptosis and LPS action. So in mild ptosis with good LPS action, we can plan for Fasanella cervid surgery. So this is a surgical video of Fasanella cervid. We mark the lid crease. This is the local infiltration that I'm giving, xylocaine with adrenaline. The lid traction suture is marked. Can you just forward it a little bit? So I mark the superior edge of the tarsus. Then a traction suture is passed at the superior edge. And again, 3 sets of traction sutures will be passed from the fornix to the near the lid margin. Then the amount of tarsus to be resected is decided by the amount of ptosis. So for every 1 mm of ptosis, we resect 2 millimeters of the tarsus. So here we are measuring around 4 millimeters of the tarsus because patient is having 2 mm ptosis. So after clamping, we just cut it with a Stevens sternotomy scissor and we directly close the incision by, this is the atriovicular suture. We don't want to put the knot on the inner side because it will rub on the ocular surface. So we put the knot outside and interiorize the suture, and with the help of continuous running suture, we'll close the conjunctiva along with the remaining part of the tarsus. So this is the end of the surgery and patient has a symmetrical eyelid contour matched with the other eye. And this is the post-op photograph. LPS resection is a very popular mode of ptosis surgery that we can do in all variety of ptosis which have some amount of LPS action, whether it's a mild, moderate or good severe ptosis. So this is by transcutaneous route. After giving the skin incision, the orbicularis is separated. Then we open up the septum. This is the LPS aponeurosis that you saw. Then we can evert the lid to inject the subconjunctival xylocaine with adrenaline for the facilitating the dissection underneath the LPS muscle. So here I'm separating the LPS aponeurosis from its attachment over the tarsal plate. And then depending upon the amount of LPS that you have to resect, you have to do the dissection. So this is the tarsus where I have to advance the LPS. This is the white line. That is the junction of the aponeurosis and LPS muscle. So I am measuring according to the amount of ptosis, and then I'll pass a suture. This is a 6/0 nylon suture. So first we'll take it from the LPS muscle, then to the tarsus, then again through the LPS muscle. And then we'll check about the position of the eyelid over the limbus. So if it's a good LPS action with mild to moderate ptosis, we can leave it 2 mm below the limbus. So 3 such sets of sutures are passed, and then the remaining part of the LPS muscle is cut, shortened. In the end, we pass the lid crease sutures and close the incision. Post-operatively, we have to look for leg ophthalmos, lid lag, and take care of the ocular surface. Lastly, I would take you through the frontalis suspension surgery. And the most ideal material to use for the frontalis suspension is the fascia lata. And we can use this tensor fascia lata. We can retrieve it with the help of a stripper, or we can use the long scissors to retrieve it. And this surgery can be performed in the children more than 3 years of age, and in adults there is no contraindication. I am doing the surgery under local anesthesia. If the surgeon is not comfortable, it can be done under general anesthesia. So this is the tensor fascia lata that we are removing. So around a strip of 10 centimeters is required for any kind of frontalis suspension surgery. You divide it into 2 to 4 strips. Then depending upon your surgical technique, you can mark the incision. This is I'm doing by the modified Crawford's double triangle method. So this is how we pass the fascia lata in double triangle technique. This is the pre and post-op pictures. In blepharophimosis syndrome also, it's a preferred method. So to conclude, I'll say that ptosis remains the most common but is still the most controversial oculoplastic entity, and careful preoperative assessment, judicious surgical planning and execution gives the best outcomes. Thank you for your patient listening.